We're very pleased to introduce our featured Grand Round speaker today, Dr. Arturo Saavedra. Dr. Saavedra has served as the chair of the Department of Dermatology at the University of Virginia since 2017. As a clinician and researcher, he specializes in the care of complex medical dermatology with particular interests in HIV dermatology, severe drug reactions, and the care of oncologic and post-transplant patients. Dr. Saavedra is originally from Salamanca, Spain, but grew up in Puerto Rico in a large family of 6. His father, a physician, and his mother, a teacher, instilled in him a love of science. He graduated magna cum laude from Harvard College with a degree in biological sciences. He then received his MD and PhD from the University of Pennsylvania with specialized training in pharmacology. He completed residency training in internal medicine at Brigham and Women's Hospital, where he subsequently served as chief resident. He then went on to complete his MBA and both dermatology residency and dermatopathology fellowship at Harvard. As president and interim CEO of the UVA Physicians Group, Dr. Saavedra is responsible for ensuring UVA health is responsive to local, regional, and national health needs and policy. In addition to his roles at UVA, Dr. Saavedra is an editor of Fitzpatrick's Color Atlas and Synopsis of Clinical Dermatology, the most widely read dermatology atlas for diagnosis and treatment of skin conditions. In his free time, he enjoys triathlon, hiking, and theater. And with that, we will give the floor over to Dr. Saavedra to hear a talk on graft versus host disease, novel concepts, therapy, and management. Thank you so much for joining us.
Well, thank you all for having me. It's exciting to be able to share an hour with you. And, you know, the magic of Zoom is that we can do this efficiently. The sadness is that we can't meet in person. So I hope that we can do that in other settings. But thanks again for the invite. Let me share my screen and make sure that you all can see it. Can everyone see the screen?
Yes.
Yes.
Okay, great, thank you. So let me just get this started from the beginning. So again, thanks for having me. What I hope to do today is to talk to you a bit about graft versus host disease, but do it probably in a different way than you've heard this topic discussed before. We'll take sort of a clinical, but also an immunological approach to this issue and think about really what's happening at the level of the patient's immunology so that we can really understand how things are to be diagnosed.
Dr. Saavedra, sorry to interrupt you. Are you sharing the wrong screen? We are seeing the outer.
How about now?
Now it's good. Thanks.
All right. Thank you very much. I really appreciate that. Thank you. And so as we begin, I'll say there are no relevant discussions of commercial interest with this. I will be discussing therapy with drugs that are not FDA approved for GVHD. As you know, there are very few of those. And I'd like to thank the Derm Foundation for supporting my career. A lot of the primary data that I'll discuss here is a result of grants from the DF. So we'll talk a little bit about what GVHD really entails, but we'll talk a little bit about vocabulary first to make sure that we're all on the same page. I'll talk about the physical exam, novel therapies, and where we're going in the future in this film. We'll specifically talk about diagnostic criteria, a therapeutic plan, and again, where we are hoping to be in the next 5 to 10 years in the treatment of this disease, which I'm really excited about because I really do believe that dermatology will be one of the foremost players, not just in the treatment of GVH, but also in an increased number of indications for transplantation based on the disorders that we see and diagnose. So let's start just talking about a little bit about vocabulary because things here will matter. As you know, when you transplant a patient, you can do so in different ways. The term autologous transplantation implies that the patient is both the donor and the recipient. On the other hand, in allogeneic transplantation, the donor and the recipient are different, and you go ahead and try to match donor and recipient so that there is a good outcome. It's interesting to note that this process of matching and how we recover these cells is more art than science. And we sometimes match or choose matches that are not perfect for very, very specific reasons. But within the concept of allogeneic transplants, you can have a matched related or a matched unrelated transplant. And in general, in oncology, when you use those terms, you are implying that you're recovering the cells after a bone marrow tap. Again, a needle going into the iliac crest and removing the cells that you are going to infuse into a patient. If the patient is related to the donor, that's a matched related transplant. If the patient is not related and you've gone into a library, then you've had a matched unrelated transplant. Now, again, remember the term match means that we're going to try to find similar enough donors and recipients, but they are not identical. They are not identical. And that is primarily the basis of GVHD. Many years ago, there were issues with donation in libraries. And one thought was, well, can we recover the cells, not from the bone marrow, but rather from the peripheral cells, the peripheral blood. And we do that actually by using an antibody against stem cells called CD34, and we pull cells from the blood. And the so-called peripheral blood stem cell transplant was at that point thought to be a home run, right? Because we would have less issues with recovery of cells and potential fear of donation. It turns out now, several years later, almost a decade later, that we know that that is the probably highest risk of having GVHD is from a peripheral blood stem cell source. And you may ask, well, how can you really recover enough cells from the peripheral blood? And in fact, you do have circulating stem cells. But in the adult, even those stem cells have seen antigen already. They're not in the marrow. So they have already been somewhat primed. And then you can imagine that a primed immune system is more likely to react against foreign antigens. And then we had a decision to make. Do we keep going back to match related and unrelated transplants and tapping the marrow? Do we sometimes choose peripheral blood cell transplants because someone doesn't want to donate knowing that we might have a much higher risk of GVH? Or are there other sources? And that's where the so-called umbilical cord transplant came into play. As you see in the picture here, we do use cord from babies, but this presents a really interesting situation in that for a child, you probably only need one cord to transplant a recipient. However, for adults, you may need 2 or 3 cords. And now you have a real immunological party going on, right? Because you have the recipient with an immune type, and then you have 3 different cords that are not identical, and you can see intra-cord interactions or cord to donor interactions. So it sets up a very, very interesting immunological profile in patients. But suffice it to say, over time, even if you use 2 to 3 different cords to transplant an adult, one of them will predominate. So now understanding where cells come from and that the match process is not ideal, the term graft versus host disease or state is simply one in which non-identical immune systems interact with one another. And that's probably easier to understand in the allogeneic setting. Understanding that in autologous transplants, donor and recipient are the same, is it possible then to have GVHD after an autologous transplant? What are your thoughts? Any thoughts from the audience about that? Can you have GVHD in the autologous setting if donor and recipient are the same? What thoughts are there?
I think it has been described. It's not common, but it's something that I try to keep in mind when I have an autologous transplant patient.
Fabulous. Exactly true. It is described, it is more rare. And the basis of it appears to be that when you recover your cells and you store them, right, you put them in certain types of diluent. Some of them have DMSO and other agents that permeabilize the cells, and intracellular antigens can be exposed extracellularly. So even though the cell itself is the same, the nature of immune interactions is a little bit different. That is one postulated mechanism, but yes, you are correct. It can absolutely happen. And so again, knowing that, I want you guys from now on to sort of remember GVHD is going to be a status of non-identical immune systems interacting with one another. But the likelihood of that interaction being adverse or being exhibited as graft versus host disease, particularly of the skin, at this point will be mostly mediated by whether you are an allogeneic transplant or not, and where you have recovered those cells. Knowing that peripheral blood is going to be the highest, umbilical cords probably in the middle, and then match-related transplants. The next topic to sort of get through and understand as it relates to graft versus host disease is why exactly we transplant patients. And early on in my career, this slide was really an important one to learn and understand, because it sets, again, the basis for how we study this disease. We transplant really for three reasons. Because you're going to treat a patient with high-dose chemotherapy for a tumor, and that high-dose chemotherapy is going to injure, if not ablate, the marrow, right? So simply as a side effect, you've killed the marrow or hurt it, and you need another marrow. The second potential reason is that you're replacing a marrow that's already deficient, one that's not functioning very well, whether that is due to mutations or whether that is due to antibiotics like chloramphenicol, whether that's due to so-called hypoplastic MDS. The marrow is just simply deficient, doesn't work, and we need a new one. But by and large, the primary reason we transplant a patient is the so-called graft versus leukemia effect. This is really important. Under the concept of graft versus leukemia effect, what you're saying is that you're going to bring a marrow into a patient that is similar enough to not cause acute rejection. The marrow is going to be accepted by the tissues, and it hopefully will lodge in bone and engraft. But you want it to be a little dissimilar from tumor, because God forbid one or two few cells are left behind after high-dose chemotherapy, and you start getting recurrence. This new, slightly dissimilar bone marrow will kind of keep that at bay, if not attack it. And that process of graft versus leukemia is what mediates really recurrence and survivability of the patient, right? So think about, again, what we've said here. We want a marrow to be similar enough to live in the patient, but dissimilar enough to identify any recurrent cancer. Now we can start using the concepts we've learned before about match-related, unrelated, and peripheral transplants to know how much graft versus leukemia we want to induce in a patient, and consequently, what level of risk we will tolerate for graft versus host disease to ensue. If you look at the table on the right, what we have learned is that different types of cancers have different types of graft versus leukemia effect, or let's call it graft versus tumor effect, so that the response against CML from a new transplant is much stronger than that to AML and that to MDS and then ALL. That means, again, that generally speaking, after transplantation, there's higher GVL or graft versus leukemia if you're transplanted for CML, and less so if you're transplanted for ALL, and very little if you're transplanted for myeloma. And that is what you see in this graph here. If you plot really the number of years that a patient survives versus the probability of recurrence, you see that you're more likely to survive if you were originally transplanted for CML versus AML versus ALL, all other things being considered. And what underlines this graph is, again, GVL. So our graft versus leukemia response is strongest for CML, less strong for ALL. And as a result, we expect more recurrence in ALL. Questions about these two slides, because this is really important for the rest of the talk. Any questions or thoughts? And stop me anytime, because the goal here is to start building on this story. So right now you're answering a consult and someone has a rash and you think it's GVHD, and you're going to go make sure that you understand whether the person received an autologous or an allogeneic transplant in terms of determining the likelihood of GVH. You're going to figure out from the chart how the cells were recovered, if they were matched, unmatched, or whether it was a peripheral or umbilical source. And then you're going to look at the indication. And you're going to know that if you're going to treat someone with steroids, you're probably feeling more confident if you're treating someone with systemic immunosuppressants if they were transplanted for CML versus ALL, because CML, again, has a very strong graft versus leukemia effect, and ALL may not, and therefore the chances of recurrence are higher. So it starts giving you a sense of how you may proceed with treatment. But as you know, GVHD will occur at specific times of transplantation, and it's important to know your differential diagnosis based on the immunological status of the patient. Generally speaking, in transplantation, the first part of it is matching, where you're trying to find, again, a donor marrow. The process of conditioning, or other centers may call it preparative regimens, is a process by which you try to kill the marrow that is in the patient at that point. That marrow may be deficient as an MDS. That marrow may be recurrent AML after chemotherapy. But you're going to, again, try to reduce that bone marrow so that you don't induce acute rejection when your new transplanted marrow comes in. That process is very, very important. If you don't cytoreduce or condition or prepare the patient, the chances of recurrence are much higher, rejection rather. The third step in transplantation is in factor transplantation and engraftment, which has very specific definitions. We'll talk about that. And lastly, the period of recovery, when the new bone marrow is setting up residence in bone and hopefully populating the patient and protecting against infection and other things. So in general, the matching process is probably my favorite process of transplantation. And that is because when someone comes in for a transplant, they may feel like you and I feel, right? They've had a terrible disease, they may be in remission, but they don't necessarily feel unwell. And that's what we generally don't see in the hospital, because we tend to admit the patients that are doing poorly. We generally will try to match with families first, depending who's donating, up to 50% chance of a good enough graft. But when that doesn't happen, then you go to a library. And particularly in minority populations, when we go to libraries, we have a much lower chance of matching given the decreased donor pools there. Then you sign up for your transplant. And your conditioning regimen will start at day -7 or -2, meaning a week before you're actually going to get the bone marrow. And those conditioning regimens change. They may include chemotherapy, radiation, or both. Different recipes, we'll talk about those in a second, but again, a week to 2 days before. And then the transplant is by definition day 0. Some patients call that their new birth date, but again, that's the day of infusion. And that's a quiet day, a little bit of a quiet day. And then the clock starts ticking, where hopefully you will lead to engraftment, meaning the cells are lodged in the patient and replicating in the patient and functioning in the patient. That engraftment, depending on the disease and the conditioning regimen, may take a week to 3 weeks, sometimes a little longer. But if it doesn't happen at all, then you're in trouble, right? And that is a stressful period for patient and doctor alike. And if you haven't grafted after around 3 weeks or 6 weeks, you begin the process of recovery. So we've spoken about, we'll talk a little bit about each of these stages. Matching is not a perfect process. It's more of an art than a science. And initially we looked at 6 different loci in the chromosome. Sometimes we can now look 10 and greater, actually. But think about that. Of all the different loci you have in your body, we're looking at very specific immunological sites in the HLA, B, and DR family. And then we simply try to find the one that fits the best. Unless we want from the very beginning to induce a state of high GVL, which we know will be accompanied by high GVHD. So we may choose things that are slightly mismatched, or we might preferentially choose a peripheral transplant because we just want that GVL to be very, very marked at the expense of potential GVHD. The process of conditioning, now again, you're going to reduce the old marrow to welcome the new marrow, is one also that has science and art behind it. On the x-axis, we map here the extent of myelosuppression, or reduction of neutrophils and granulocytes. On the y-axis is immunosuppression, or the reduction of primarily lymphocytes, white lymphocytes. And what you see here is that depending on what regimen you choose, you preferentially target white cells or lymphoid cells, or both, again, across the identity line here. But when you look at this graph, you see something really interesting. you see that some regimens will not really deplete the marrow. Those are called non-myeloablative. There are others that are better than that, but don't completely destroy the marrow, as would be the case with myeloablative regimens. So as you start again thinking about GVHD and the incidence and the prognosis, also understanding the conditioning works, because presumably in myeloablative regimens, you would have less immune disinteraction because you've reduced the cells to a greater extent before you bring in a transplant. This is again where incredible basic science and clinical science join. Myeloablative regimens are incredibly toxic, as you guys know, and carry a significant upfront mortality in patients. And age being one of the most prognostic factors in how well you do in myeloablative regimens. The term reduced intensity has allowed us to perform transplants at a much later age group and in a much worse illness burden of patients, because you're not going to completely destroy the marrow, but you will reduce it enough so that you can accept a new marrow without causing rejection. So that so-called reduced intensity conditioning is a very, very important term to understand, because it means that we have expanded the total population that would qualify for a transplant, or at least do well after a transplant. And during this time period, the rashes to really know about during the conditioning regimen period are again chemo reactions and hypersensitivity reactions, radiation burns, if someone has had mostly radiotherapy for preparation, and mucositis. That's really your differential that you're looking at if you're called for consults. The transplantation period, as we talked about, is the infusion time, day 0. And then you're going to be actually measuring cells to see if you've engrafted and you have allowed the bone marrow to, again, lodge or niche these cells. The term engraftment implies that your total absolute neutrophil count is at least 500 for 3 days. What you do is you add on your differential the total number of neutrophils to bands, and you multiply that times the total white count. And if that's at least 500 for 3 days, you've engrafted. When you don't engraft and everybody is getting anxious, what can you look at to make sure that maybe this is just a little delay, but will in fact happen and engraft? The first cells to return generally are monocytes, so the appearance of monocytes, although they do not contribute to the ANC and the term engraftment, kind of herald the coming of the marrow. So looking at monocytes is important, as well as red blood cells. And then you get to the process of recovery. Hopefully you've engrafted, your bone marrow is pumping out new cells, and those cells are functional. They generally are not in the early period. You can have reactivation diseases and are still susceptible to sepsis, but cells are at least replicating. During the recovery period is when your differential diagnosis gets a little bit more complicated. In the very, very early recovery period, now we're talking 21 days, you may have the so-called lymphocyte recovery rash. That's a controversial entity that some dermatopathologists may or may not diagnose. But certainly after week 4 or 6, you can start getting so-called acute GVHD versus, again, drug rashes, viral reactivation, or chronic infections from an immune system that has lodged but is not fully functional or mature yet. And this is just a graph that you can refer to later, showing again where things happen based on the reconstitution of that immune system, or how awake or aware it is in the patient after your engraftment. I'll specifically point out that early on, bacterial and fungal infections and HSV occur predominantly in the early period versus VCV in the post period. So now we've talked about this process again of matching, conditioning, transplantation, and recovery. This is just again to specifically show you some terms used in the literature around GVHD, but to review, a week before the transplant, most of the derm differential diagnosis will be around drug rashes or radiotherapy burns. The very first early days, again, are delayed responses to total body irradiation or radiation recall. Very, very early on, 3 to 7 days, the so-called lymphocyte recovery rash, hyperacute disease, 2 to 3 weeks in, and thereafter acute GVH. The term hyperacute GVHD is important to talk about because these patients present with erythroderma, very, very high fever and peeling. Sometimes it can resemble toxic epidermal necrolysis, and that's a difficult diagnosis or differential diagnosis to work up, because as we'll talk about in a second, the clinical and pathologic findings are almost identical in toxic epidermal necrolysis and hyperacute or desquamative GVH. But in general, the acute term for GVH will involve predominantly 3 organs: your skin, which you're all masters in, the liver, and the gut. Unlike chronic disease, which we'll talk about in a second, really can take about just any organ. Some believe these disorders to be in a spectrum of the same condition. Others, like me, believe that they're 2 different diseases, but we'll talk about that in a bit more. And the way that you clinically grade these patients is important to talk about, because in the literature, these terms are used consistently. The stage of GVHD refers to an organ, and the grade refers to all of the organs involved in a patient. So a stage system for skin disease would be 1+ or stage 1 if you have 25% or less of your total body surface area involved. Stage 2 if it's between 25 to 50% of your total surface area involved. 3 if erythrodermic, and 4, as we discussed before, if you have desquamation or blisters. You can do that separately for gut and liver, and then refer to your table for your overall grade. So if you're doing research on GVHD specifically on skin, you might report stage. If you're looking at patient survival and overall health status, you would report grade. And in general, for acute disease, your risk factors are the ones that you would predict based on the immunology that we have discussed. If you infuse a marrow that's not identical to your recipient, i.e. HLA non-identical stem cells. 2, as we've discussed, again, peripheral blood stem cell transplant. Again, the biology there being that these circulating stem cells, although they can further differentiate, have already seen some antigen and are therefore more alloreactive. Patients that don't receive GVHD prophylaxis are at highest risk for GVH. The extremes of age, older and neonate. In pediatrics, those who are particularly transplanted for congenital immunodeficiency syndromes are high risk for GVH. Again, that's mostly children. And then solid organ transplants with specific high risk in small bowel transplants, which, as you know, the small bowel has a ginormous amount of lymphocyte burden in the setting of mouth tissue, similar to skin. So we had discussed this issue of desquamative or stage 4 GVH, and this is a consult that is hard. It's just hard. And let's see why. The reason is that stage 4 GVH can masquerade or look like toxic epidermal necrolysis. Both disorders have high mortality, right? Which almost makes you feel like you're not gonna win. Both states generally are in complex medical patients, but treatment is different. If it's desquamative GVHD, you're going to add immunosuppression. If you are diagnosing TEN, you're going to stop medications. But if you make the wrong diagnosis, you err on the worst possible end, right? And if you really have acute GVHD and you should be adding immunosuppression, but you don't, and instead stop medications, you make the patient have 2 potential comorbidities, infection and progressive GVHD. And the opposite is, of course, true of TEN. So let's play a game here and let's have a voting game. Then what can we do at the bedside to differentiate these patients? I'm going to show you 2 patients. This is patient number 1, and then I'll show you patient number 2. One of them has desquamative GVHD and the other one has TEN. And we'll talk about later how those diagnoses are made. But is there anything that we can hang our hats on clinically? Again, patient 1, patient 2. I'll go back and show you 1. And then I'll show you patient 2 again. Anyone has any thoughts? Which patient has GVH? And is there anything we can gauge from the clinical exam? if you had to guess? Any thoughts?
One seems a lot more truncal and the other's more peripheral. I'm sorry for interrupting.
Great.
The hands and feet, I think I would think of more GVHD, although we are seeing hand and foot involvement with TN with some of the PD-1 inhibitors. So I don't know, that would be my thought.
Excellent. You're like a plant. It's exactly what you wanted to say. So if you have to guess, and you have nothing to go on, acral disease favors GVH, but you are absolutely correct. It's at best 65 to 70% specific sign. So God, you know, our clinical exam helps us just about that much. But you're right. It's patient number 1 is mostly a truncal distribution. He does have this desquamation around the hair follicle, that punctate area in the proximal thigh, as opposed to this patient who has predominantly acral disease, and boy, that's full thickness desquamation, absolutely favoring GVH in patient 2. The challenge is that then we'll biopsy it, we'll send it to the dermatopathologist, and what we'll see is this, right? Full thickness desquamation with this keratotic cells and a scant inflammatory infiltrate. Again, not very specific for either. And so what else do we have? This data is a little bit old now, but it proves a point. Investigators in the University of Michigan looked at this specific marker, selecting it after very complicated spectrographic processes, actually. They identified elephant, which if you stain tissue or if you measure it in the blood, high level staining in high amounts of production in tissue favor GVHD. And so you might say, how come this is not available in my hospital? How come I haven't heard of it? And part of the reason is it never obtained approval because there wasn't a purported mechanism and it wasn't entirely reproducible. Elephant is actually secreted by neutrophils, and we know that GVHD is predominantly lymphocyte disease. So how do we put that together? There will be more about this coming in the future, but I just wanted to introduce the topic because it has been out there and not yet clinically utilized. But one other thing we can do is actually look at the inflammatory infiltrate. As you can tell in the left column, we have a disease which is very inflammatory and tons of T cells are there. CD3 is pretty darkly staining, followed by a much higher ratio of CD8 to CD4 cells. On the other hand, in the right column, we see a disease that's slightly less inflammatory, but where the CD4 count in respect to CD8 is much higher. These experiments were done entirely identical to those with cutaneous T-cell lymphoma, just to look at again at the profile of the immune cells. And on the left hand is what you actually would see in TEN, CD8 predominance over CD4, and in GVHD, the opposite, and a ratio of greater than 4 for CD8 to CD4 generally favors TEN. So moving on then to chronic disease, is this the same disease or is it different than acute disease? Well, we know that there's an artificial boundary that we no longer use at all. We used to call chronic disease anything that happened after day 100, but now we do know that you can have recrudescence of acute GVHD after 100 days. And so we now know that the definitions hinge more on clinical exam manifestations, but we do know that rarely would chronic GVHD happen before 80 days, and only 5% of new cases after year 1, because as you know, the disease can endure and persist. And quite frankly, very little is known about this disease other than the role of steroids and how we utilize them in this disease, although more and more data is coming up every day. To the point of whether acute and chronic disease are the same and different, this is some data to consider. Yes, in some patients, acute disease is followed by chronic disease. But in about 30% of patients, chronic disease happens without ever having any acute disease. And the converse is also true. About 30% of acute patients don't ever develop chronic disease. So are they the same or different? We'll learn more about that, but we know that there is a spectrum. I will show you one case in which acute disease does progress to chronic and what features may be important to consider in clinic and to teach your colleagues outside of derm about, because often these patients see primary care doctors and internists, and you don't want to miss them. But this patient here presents with again, the exam that you see. I won't describe the exam on purpose, but I will tell you that this patient complained of burning, right? Not pain, not tenderness, burning. And was treated as cellulitis, actually, with oral antibiotics. And it did get better, but it took about 6 to 8 weeks on chronic antibiotics for this leg to get better. But then that leg kind of became this leg. And here you see a lot of kind of superficial scaling and eczematous kind of reaction. And he was diagnosed with acetotic eczema in this case. To the careful examiner, again, you see these sort of bubble gum pseudomyxoid nodules. This is a very, very, very important finding in realizing that this is early chronic GVHD. And again, these pseudomyxoid nodules, if not treated like GVHD, eventuate into this leg, which is that same patient. So one of the lessons here is new onset eczema. New onset eczema post-transplant period is a diagnosis you should reconsider, and is only a diagnosis of exclusion. Look specifically for these pseudomyxoid nodules, as they may give you a clue that the patient is at risk for sclerodermoid disease. The pathology is different in these disorders, not just in pattern, but also in physiology. If you look at chronic disease, that's really a very inflammatory state. We generally diagnose as late when it's in the fibrotic stage, but there is inflammation there. Acute GVHD, on the other hand, is more a disease of necrosis and apoptosis, like you see in erythema multiforme, right? So very, very different immunologic burden in those diseases. And what you see here in acute disease is, yes, a perivascular lymphocytic infiltrate, but more specifically a vacuolar dermatitis with the so-called satellitosis. And satellitosis is the term that describes a live lymphocyte next to a dyskeratotic keratinocyte. And you see that at several points of that vacuolar dermatitis. Compare that with chronic disease, where you see foci of inflammation as far down as the mid-dermis. You do see your fibrosis, again, pockets of inflammation, but I'll direct you to the epidermis. This is a really interesting situation because I will tell you, when I show this slide, people immediately say, oh, this is a patient with SCCIS, right? You've got dysmaturation, you've got tripolar mitoses, you've got severe atypia, but this is normal skin in a GVHD patient biopsied. And so I want to add to those histopathologic findings that in chronic GVHD, you have a state of epidermal dysmaturation. And so now you can imagine in the setting of chronic inflammation, as you would see in a marginal ulcer, for instance, right? That chronic inflammation leading to SCC, these patients live in almost a pre-malignant status at any point just around in their skin. So maybe not so surprising anymore that extra sun protection, sun exposure or extra immunosuppression may turn this into an invasive squamous cell carcinoma. This is often something that we struggle with too when we do excisions, and margins may be potentially involved. Tough call to know when to stop or not to stop. Based on these findings, generally, again, field therapy can be helpful, but not worth putting a huge hole over areas that are not invasive, particularly over fibrotic skin. And again, to show you really high level disordered, prominent nucleoli, tripolar mitosis in skin. And this is really the most serious complication of transplantation for many reasons. 50% of patients will have 3 or more organs involved. So it is a high disease burden, and generally they will require a long period, very, very long period of immunosuppression. But also importantly, it is the cause of very much decrease in quality of life. And reports and data suggest that patients, in quality of life studies would exchange years of life to avoid some of these complications. There are at least 6 types of chronic disease that have been documented and published, sometimes under different names. The so-called acetotic or cirrhotic GVHD you have seen before here on the left, The diagnosis is made by identifying the pseudomyxoid nodules, again, that pink bubblegum kind of look. The so-called ichthyosiform disease does look like ichthyosis. It is generally a disease of children, but unlike ichthyosis vulgaris, plates may not be confluent, and there may be a seemingly normal intervening skin in between the ichthyotic plates. Lichenoid disease is really a terrible name. Some people prefer to call this lichen planus-like disease. The Japanese call it psoriasiform GVHD, but suffice it to say, as seen here in the left, they are these sort of guttate plaques with surrounding erythema, sometimes turning violaceous. On the right is sclerodermoid disease, probably the most dreaded subtype. It has the highest rate of pulmonary involvement and mortality. And quite frankly, if patients don't ever recur from their cancer, they're most likely to die of this type of GVH. Vitelliginous disease on the left, also predominantly a disease of children. Note that the area of vitiligo is actually inflammatory, pretty red. And then the so-called bullous GVHD, which also carries a very, very high mortality if untreated and unrecognized. The mouth can be super helpful in making the disease of making the diagnosis of chronic disease if there's any suspicion of it. On the left upper panel, what you see is posterior pharyngeal desquamation. In the anterior part of the larynx, you would see regular mucosa and then desquamation in the back, almost towards the center of the uvula. On the right upper panel, what you see is effacement of the papillae of the tongue. Note how this looks like very smooth tongue. It doesn't have the corrugations of your papilla. Generally, patients at this point will not perceive salt or sugar very well. On the left lower panel, you see desquamation of the inverted aspect of the lip, and then the so-called Wickham stria in the buccal mucosa on the right lower panel. All features of chronic GVH. Now, just about everything I've told you so far is true of adults. Children are a little bit different, and there are 3 reasons for that. First, the indications for transplants are different. In children, roughly about 50% of all newcomers will come in for immunodeficiency states as opposed to active malignancy. In adults, it's much higher malignant indication. Conditioning treatments are very, very different. We use combination treatments or chemotherapeutic treatments in adults. A lot of kids are conditioned with radiation. And lastly, we rarely use peripheral blood cell stem transplants in children. They are used in rare circumstances, but at much lower frequency than in adults. So those, again, creates different morphologies for GVH, slightly different treatments, different complications, and different ways of manipulating the immune system. So how do we manipulate that immune system? This list is not to try and make you understand all the various treatments, but just to identify that we've thrown just about everything we can at this disease with some, but insufficient progress. We do know that corticosteroids are really helpful. 2 milligrams per kilogram for acute disease, 1 milligram per kilogram for chronic disease. But after that, very little guiding data. And often there's regional variation according to transplant center. Sometimes these decisions are made based on chronic medical problems that indicate or contraindicate a drug. But suffice it to say, some paucity of data as to what to proceed to next after steroids. So it's often really important to look at the pathophysiology. And most of us have been taught to think about the first step in pathophysiology, donor T cell expansion. Again, a state where you have 2 cell populations that are fighting one another. And we treat that by inhibiting that interaction by using steroids, immunosuppression. But as it turns out, the second pathophysiologic step is becoming more and more utilized. And that is tolerance, inducing tolerance, meaning to immune systems that are going to cohabitate with one another and maybe not argue and fight as much. The question is how to induce that state of tolerance, and we'll talk about that in a second. But this is really where most of new interest is being placed. Yes, cytokines are released that cause fibrosis and could block cytokines. We could block B cell activation, and there is a role for rituximab, which we will discuss too. And lastly, preventing tissue destruction in the setting of acute disease. So think of these pathologic mechanisms when you bump into patients, because if you're maximally immunosuppressed and you've already exhausted your immunosuppression options in stage 1, or those might be limited because the patient is now having PTLD or another state, think about going to the other mechanisms, right? Is it inducing, tolerance? Is it impairing B cells? And intolerance, again, a ton of information and interest right now. That the classic state of immune tolerance was initially the use of ECP, where through very complicated basic mechanisms, which we'll slightly discuss because there's a little bit of hand waving there, we basically remove the red cell portion. White cells are then separated outside the patient, and UVA is injected at that point and then circulated through the machine. Once those cells have been photophoresed, they're reinduced into the patient. And that process induces apoptosis and exposure of several molecules and the induction of monocytes that we think over time creates kind of a vaccine-like effect between the immune system and the patient. So again, note, it is not immunosuppressive. It is, call it immunomodulatory or tolerogenic. The process is well tolerated. It can be done through a peripheral IV, though a lot of centers don't prefer that because it decreases the time of the procedure and induces, right, a stick every time the patient comes. It can be done through a line. Longer lines take longer to photopherese, but you can see that patients can, read, watch TV in the process. It's an ambulatory procedure that is expensive. Even though only about 2 to 5% of the total leukocytes in the blood are treated, and you actually reduce exposure of UVA to the patient than you would if you did PUVA, for instance, and also have a much lower risk of malignancy. Each treatment is about $7,000 to $9,000, depending on where you live and what your contracts are. And for a procedure that may require 3 to 2 times weekly treatment for 12 weeks or more, that's a high cost. This just shows you again some of the mechanisms that we talked about by photophoresis, but again, not entirely understood. But what we do know is that photophoresis, by inducing tolerance, is predominantly a steroid-sparing regimen. So not greatly helpful as monotherapy, more helpful, as you see here on the red line, in its ability to decrease the amount of steroids that patients are exposed to, generally to about 10 to 5 milligrams. And then here you can see again how you have changes in the skin texture, as well as the total steroid dose that is reduced based on photophoresis. So again, think of it as an adjunct to lower your steroids. But then, are there other ways of inducing tolerance? And again, this is where I think we're all incredibly happy and privileged to be in academic centers, because when really intelligent minds come together, fantastic observations are made. As you know, interleukin-2 is used at high dosages to treat some tumors, in the past melanoma and, for example, renal cell carcinoma. And IL-2 is a mitogen to T cells, meaning it expands them, makes more of them, and it makes them active. But what is interesting about that response is that if you use it at high dosages, you activate different types of T cells than you would activate if you used medium dosages. And in this paper, what was shown was that at medium to low dosages, you preferentially activate Tregs as opposed to cytotoxic cells at high dose. So you might turn up the volume in IL-2 and at high dose treat a tumor, right? RCC or melanoma. But at mid dose, you might specifically activate Tregs that may induce a tolerogenic state. And that's what was actually seen in patients treated over time. In panel A, you see an inflammatory sclerodermoid patient, which much decreased inflammation and mobility at the truncal and lower extremity levels after treatment with IL-2. That requires injections weekly. It has been in low supply. It is harder to get, but very helpful. And what's nice about that data is that it maps the clinical response to an immunological response and a decrease in what's why we call it TSS, the skin score, with a concomitant increase of Treg cells. So now that we talked about two different mechanisms, immunosuppression in order to target donor or expanding T cells, photophoresis or IL-2 targeting tolerogenic mechanisms, B cells have also been shown to be contributing to the state of GVHD and blocking them to improvement in disease. It is not the first thing you will do. It is generally something that you will use lower down in the ladder when someone has shown to be either steroid recalcitrant or has recurred in disease. And as you know, rituximab blocks B cells at the CD20 receptor, and a treatment of about 375 milligrams per meter square, which is the dose for non-Hodgkin's lymphoma, weekly for 4 weeks, is probably the best recipe or best studied protocol. Is very, very helpful. And as you can tell in this population, a few of those patients had already had ECP. So again, these are treatment resistant and steroid recalcitrant patients. More data coming down the road, specifically around preventing cytolytic destruction and preventing fibrosis. The drug Rezurock is now being used again, targeting fibrosis and tissue deposition, both in the skin and lung tissues. The drug Halofuginon, not used in this country, available in Australia and in Europe. It's actually a medication used in animals. It's a veterinary drug. It's a coccidiostat. It's used to treat cocci, but it inhibits the PDGF promoter, particularly when fused with collagen 1, and has been used for both scleroderma and scleroderma GVHD. Complicated reasons for why it hasn't made it to the States, but watch out for this drug. It may come to a theater near you. So then how do we consider therapy? Knowing these three different mechanisms, but also knowing the immunological status of the patient. Well, we look at extent of disease, right? And given that we know that systemic immunosuppressants have a higher risk of recurrence by reducing GVL, we tend to strongly consider when there's functional limitations in order to pull the trigger for systemic therapy. We look at timing of disease. Earlier on, we talked that very few patients, if any, will develop GVHD after the first year. And if they develop disease, it can burn out by year 5. So the closer you are to year 5, you may be less likely to turn on systemic therapies, again, to prevent recurrence. You look at whether the patient would qualify for a second transplant, right? Are they old and therefore don't qualify for a second transplant? Did they have many choices of potential donors, particularly if they're a match unrelated? You look at all of these things. Should you overshoot and decrease GVL and lead to recurrence? Other new therapies coming down the road, OX40 ligand, both an immunologic and immunomodulatory mechanism. We specifically depleted T cells during some forms of transplants, or actually injected Tregs. This last mechanism has been very, very, very helpful in some areas of the country. So we've talked about the mechanisms by which we extol the virtues of a new system or new immune system in inducing GVL, the indications for transplant, age, and again, how to manipulate that immune system to prevent recurrence, but also at the risk of inducing disease. And then about 3 pathophysiologic mechanisms that we can extol for treatment. In the future, I really do believe that not only are we going to be sending patients for transplantation, we've done that already for things like LYP, for things like Langerhans cell histiocytosis, most recently scleroderma, sometimes lupus. So we'll be involved in sending these patients for transplant, but also not only just seeing them in the hospital when they're comorbidities, but as they survive and reintroduce into society and come in for other comorbidities, whether it's skin cancer or recurrent of disease, I think will really guide a lot of this care in a super exciting time in GVH. I know that we only have 6 minutes left, so I want to leave some room for some questions, but also to really thank you for your time, for your attention, and for inviting me to share with you for an hour. Thank you very much.
Thank you for that
so
great.
much. Oops, sorry, go ahead.
I was going to say thank you for that great talk. I have a question. Well, two questions actually. I didn't see JAK inhibitors on your immunosuppressive list, and I was just curious what your thought was. That's more, sort of inhibiting activation of T cells. That first
Correct. Great
process. Do you think of it just like prednisone, where it's not really, a great long-term option if we have these new emerging therapies, or do you like it?
Yeah, so thank you for that question. The reason I purposely didn't put it in here is because there's not exactly guided protocols to when to use it, and there's regional variation. In our center, in my experience, we usually use it in patients who are treatment refractory, meaning that you can't taper off the steroid. Yeah, exactly. So in patients that you can sort of slowly taper steroids and they recur and they need another shot of steroids or a steroid sparing agent, that's a different group of patients, as opposed to those who are in high dose prednisone. You can't taper in spite of a second agent, you can't get them off, you may consider phototherapy, and that's where we've used JAK inhibitors. And quite frankly, I really do think that their use will increase and be earlier on in that protocol, because they're, again, in my experience, very, very effective in the early to mid course sclerodermoid disease. Point well taken. And thank you for the question, but I did that exactly on purpose.
On purpose, I figured. I was like, wait, he's not mentioning this thing.
Yeah, exactly. To decrease bias.
And then the other question I have is, like, do you think that we should stop using this word acute and chronic? Like, should we just throw out the current terminology and come up with a different way to talk about this?
Yes, that is an awesome question. And I think the answer is yes. Part of what I've tried to do here is to show you how this disease is not, there isn't one input to this disease, right? The state of the patient is important, why they were transplanted, how they were transplanted, the extent of their immunosuppression, whether they're transplanted for cancer versus immunodeficiency states. And I think in the future, we're going to describe this based on the immunology and the interaction between graft and donor. There are tests already that aim to do that. I am sure they are used in your center by oncologists. The so-called chimeric studies will look at the relative proportion of cells that are circulating that belong innately to the patient before the transplant versus the cells that are graft. And that's sort of an indication of recurrence, but it can be an indication of other things. I think chimerism and some specific biomarkers in the future will be how we'll more specifically grade this disorder and even describe it as distinct disorders. Yeah.
Right. Yeah. That it will be like personalized GVHD medicine. Yeah, exactly. I totally agree. I just get very frustrated when they're like, this is acute or chronic or whatever. I'm like, it doesn't matter anymore. Who cares? Like, they have it. That's right. I mean, it matters, the quality and the type they have, but I think we've historically, all the studies are based on this, but it doesn't really make any sense. So I'm glad to hear that things are improving in this area.
Absolutely. And if you talk to a hematopathologist or an oncologist, there's so many diseases that we used to call morphologically leukemia or lymphoma and now have different disorders only based on flow cytometry, right? And I think that will happen to GVHD as well. Yes. So thank you for that question.
Thank you.
Yeah. Other questions? Guys, well, again, thank you so much for your time and attention and your invite. It's really an honor. And if I can ever be of help in any way, this is my contact information. I look forward to meeting you all in in personal settings when that is safer, and if not soon at the AAD. Thank you so much again for the invite.